Thank you very much for the honor of presenting in front of you. I'm going to try to convince you in the next 30 minutes or so that if the conditions are right, hospitals can work together. And when those hospitals work together, a lot of good things come from that. And there may be some parallels to the military, although I'm going to leave that to you to decide, but I'll describe our system. But I have one little anecdote I want to tell you before I start talking here. I was never been in the military myself, but I do have a little bit of a connection because my dad was a general surgeon. And he trained at the University of Michigan just as I did, and graduated at age 32 or so with having his boards. That he just passed his boards, and then 18 months later he found himself going in on D-Day in Normandy. And that was an experience he didn't talk a lot too much, but I recently was rummaging around through some old boxes in my mother's basement, and I found his operative notes from the first 3 or 4 months of Operation Overlord, basically, and I'm currently writing that up into a paper. It's fascinating to look to see what kind of procedures were done, basically in a ditch on the beach, and maybe someday you'll invite me back to come and talk about that subject, but it's totally fascinating. I want to speak a little bit now to follow on Dr. Bohr's talk about the future of medicine and how we need to work together to adapt to the changes that are happening. And I'm going to describe something called the Michigan Surgical Quality Collaborative, which is actually now more 12 years in its existence. Uh-oh, don't tell me. Well, this work? There we go. So this is what it looks like. There are 73 hospitals in Michigan these are all big acute care hospitals that belong to our system. Every penny of this is paid for by Blue Cross Blue Shield of Michigan because they see that it's in their interest. And you can maybe think of that as the DOD or something similar to Blue Cross Blue Shield, but they support all our activities. Every one of these hospitals has a designated nurse that collects data that we tell them to collect. They have standardized definitions, standardized risk adjustments, standardized outputs. So it's all apples to apples on the data that's sent in to our server at the University of Michigan, where I'm a professor. And we analyze the data, and we send the data back to them, and we try to make some sense of what we find. The culture of this is very, very important, and I wanted to show this slide. This is a slide of Shukri Khoury and myself. Shukri was a professor of surgery at Harvard and the chief of surgery at the West Roxbury VA for many, many years, and one of the friendliest men I ever met. And it convinced me that if you're to have a collaborative of hospitals working together, we can't be at each other's throats. We have to be in this idea that we can work together, we're all trying to do the same thing, and we're collegial. And that's, I think, the success of our group is based on that. And this is sort of a takeaway slide, is how I think quality is improved on a population level, and particularly with regard to surgery. You have to develop a registry that you believe in, whether it's NSQIP or the one that we use. Use the registry to examine variation in quality. And there's variation in everything. Some hospitals do well and others don't do so well. We identify the best performing hospitals. We then go into those hospitals and look at their data and identify best practice in the best performing hospitals and then distribute that information. It's as simple as that if you can keep the hospitals together. So disseminating the information is really the most important thing, because in medicine, as you all know, we don't do that very well. We go to the American Surgical or some other kind of meeting, somebody stands up and gives a talk, and then it takes a year before it ends up in print. And there's data out there that it takes over a decade for it to get to the bedside. So that's not a very effective way of distributing information. But when the hospitals get together in this way, they can be more effective. And we have quarterly meetings where we all get together in a room like this, 300, 400 surgeons and nurses every quarter. We have an annual meeting. We have, every month, we have surgeon champion conference calls. Each one of these hospitals has a surgeon that's designated to be in charge of it. Twice a month, the nurse reviewer conference calls. We have a newsletter. We have workshops. We have web tools. And we make site visits. So I think this is one of the most fun things that we do, and it's a great way to get information that you ordinarily wouldn't get. We take our team, and we go into a hospital that we think is performing very, very well, and we sit down and talk to every person at every level that has anything to do with the surgical patient, and we find things that you just wouldn't find by looking at data. For instance, one time I remember we went into the operating room and I said to the nurse in the operating room, you know, your surgeon's got really good results, and I'm thinking it's because he uses ertapenem for all his, at least that's what it came out in the data, that maybe for his colectomies he was using ertapenem routinely. And it was kind of fluffy of whether that was really the case or not. And she said, well, yeah, but I've been working with this doctor for the last 17 years. I know exactly what he wants to do, when he wants to do it, and it was a very, very efficient operating room. And it made me think that there's some factors that we don't usually measure that we should take into account when we try to analyze what, what good results come from. And this is one of the things that I really like to do is to get experts from our community. These are not all professors. Believe me, there's very few professors in this group. These are people who are out in the field doing the operations, and we get up and we put difficult questions to them about what they want to do, and the 300 or 400 in the audience can hear what the very active colectomy surgeons have to say. This thing doesn't really want to work for some reason. There we go. So, Dr. Bohr, I won't go over this. This is sort of a continuum. He just described that very nicely. But this, path we're taking from what my dad did as a solo private practitioner for 30 years was fee-for-service, but we're out of that now, going to pay for performance and ultimately to some kind of capitation, I think, which is what we need to adjust to. But how do we do that? So we talked about what value is quality divided by cost, and I would add one thing, I don't have enough time to talk about it, but another very important thing when you're talking about capitation is to have a slightly different equation, and that is the value is equal to appropriateness times quality divided by cost, meaning that if the quality is good and it doesn't cost very much, but the patient didn't need the operation in the first place, you haven't done anybody any good. There's no value to that. So part of what we do in our collaborative is look at that issue of appropriateness, and maybe on a different day we can talk about that. So the first thing we have to do is decide what quality really is. And that's a difficult thing, and because this is SAGES, and I wanted to, be somewhat relevant to what the SAGES group is interested in, I decided that we would talk about colectomy. But I think it's really important that the clinicians decide what quality really means, because when we get things from external agencies that are based on administrative data, and they define what they think is quality, it's terrible. It doesn't make any sense to the clinicians at all, and they won't participate with it, and they, it just changes their attitude towards everything. It's not good. So clinicians have to do this. So it's also important to focus on something. We've got a number of different areas we focus on, but as I said, I just picked colectomy because that's something we can all relate to. It's commonly performed. The surgical technique is changing rapidly, and there's a high incidence of complications, and you wouldn't necessarily want to pick, pancreatic duodenectomy because there's a lot of complications, but, it's not very commonly performed in most community hospitals. But so we picked something that was kind of in the middle, and that we picked certain CPT codes. There's no rectal cases in what I'm going to show you, or no diversions in what I'm going to show you. It's just a single intra-abdominal anastomosis on the left, right, or middle. And we measure if you're familiar with NSQIP, these are many of the same kinds of things. I had my origins in NSQIP years ago. But these are we have a definition for each one of these kinds of complications that you're all familiar with, and there's a lot of resource utilization that we measure too. So the nurses are all collecting this stuff and entering it. They're getting it out of the electronic medical record, and then they're deciding whether it fits or not, and then they're sending it into our server so that we can look at it in various different ways. So one of the things we decided to do, and this actually was my patient, if you're sort of appalled at that case, I was too, but that was my patient. But we decided that we were going to concentrate on SSI in Michigan. So one of the first things we did, and this was an interesting subject, we had a kind of natural experiment in Michigan because over time, about half of the colectomy surgeons had gone away from the Condon-Nichols prep, which, as you remember, was the mechanical bowel preparation followed by an oral non-absorbable antibiotic. And half of them had gone away from that and were just using a mechanical prep. And so we said, well, let's just take a look at that. We can do some fancy statistics and propensity analysis. And we presented this paper at the American Surgical, where you see the black bars are the mechanical prep only, and the gray bars are those that had oral non-absorbable antibiotics as well. And so that looked very convincing to us. And subsequently, there's at least 10 papers that have come out in the last year corroborating this particular finding. And so we thought, well, if that's one thing that's affecting the SSI rate, what are some of the other ones? So this is, again, one of the benefits of having a big group like this. You get a big database very quickly with that many hospitals. So we decided to put all our data in a big, bucket, and then use a logistic regression analysis to analyze our data. What are the factors that fall out independently as predictive of lower SSI, lower wound infection rate? And here's what it looks like right here. You can see that red vertical line there is 1.0, and anything where these error bars don't cross 1.0 are statistically significant. So these are the factors that came out as significant. The SCIP1, if you remember, that's the one about antibiotics administered 60 minutes prior to a skin incision. That did not turn out to be important in our group, but the rest were. One was normothermia. The other one, again, was bowel prep with oral antibiotics. Another one was a laparoscopic approach, short duration of surgery, glycemic control, and SCIP2 compliance, meaning using one of the broad-spectrum antibiotics that are on the list recommended for colon surgery. So now we took all those pieces of data. This is just Michigan data, and we said, well, let's think of this in terms of a bundle and look at how SSI rates varied by how many bundle elements were present in each individual case. And this was the most remarkable finding. We published this, but I honestly thought it looked like somebody drew it. But it was the adjusted SSI rate on the y-axis, and then the number of bundle elements that I just showed you on the x-axis. And you got to 6 when there was 150-some cases where there were all 6 elements. There were no infections at all. And you see this kind of interesting relationship. The more bundles elements you had, the better it was. So we then took that information, took it back to the folks that work together, and we said, listen, this is how we're doing at a statewide level. And on the y-axis is the number of bundle elements. It's been sort of adjusted, so don't worry about what the number actually is. Actually, the mean line that's going horizontally is about 3.3. So each colectomy patient in Michigan had an average of about 3.3 bundle elements. And on the right side of the graph are green bars that did not cross that statistically normalized number. And so they were high outliers, meaning good. They had a lot of bundle elements in those hospitals. And then the ones in the red bars that didn't get the memo or something, and they were not participating with this, and they had a smaller number of bundle elements per case, and that correlated quite nicely with results. The green bar hospitals did much, much better than the red bar hospitals. So now we're on to something. We've got something that came from our data. We've got something that we can pitch to the hospitals in Michigan, and then now, I don't have time to show you this, but we give data back on a real-time basis on how they're doing with regard to their compliance with that colectomy bundle, and you can see what's happened to our SSI rate for totals over elective colectomy for this period of time. It's been a dramatic reduction, and so everybody's happy about that. But now, if you think, well, okay, so let's use SSI as a quality metric for colectomy. Well, I don't like that, and you probably wouldn't like that either, because you could be a pretty good surgeon and have some superficial wound infections to screw up your data. And so I don't think anybody should just be judged on that one kind of parameter. So we decided that we would instead put together a colectomy composite, in much in the same way the Society of Thoracic Surgeons has put together their CABG bundle, which they have the bundle, a number of different domains, internal mammary artery use and so forth, that they put together. And so we just copied them, basically, and we said, we'll put domains together that have to do with mortality, morbidity, any one of 20 different complications that we have in this thing, whether or not they had an anastomotic leak, the 6 process measures compliance with I just showed you, and utilization, which had to do with length of stay outliers and readmits and reoperation. We put that all in, kind of mush it together in one kind of ultimate score, with 100 points being the highest. And so what now I'm showing you, hospitals in Michigan in the MSQC, here's the best quality composite for colectomy, is 100 here. And this is the different hospitals. So you can see there's variation here. There's some hospitals that have quite high quality, and there's other hospitals that have lower quality for this quality composite. And I think that is what we've decided works best for us, because the surgeons like it, because they say, okay, you're measuring me on a lot of different things that we've all agreed are important, and we can work with this rather than just SSI itself. Okay, now the second thing is we have to define cost if we want to come up with this value equation. So, but that's not quite as easy as you think it is. First of all, does it include the pre-admit testing? How about the index hospitalization only? Is it 90-day follow-up, 30-day follow-up? What about professional fees and consults? All this other stuff that could be put into a cost. And to add on to Dr. what Bohr said earlier on, I want to make a distinction here before I show you this data. He knows what the costs are in his hospital because he's the CEO there. I don't know what the costs are in all these 75 hospitals across Michigan, because hospitals have different cost accounting methodologies. So it's really hard to compare the actual cost in a hospital across 73 different hospitals. You can't do it. So what we did instead was we got payment information from Blue Cross Blue Shield. They do have all kinds of information about what they actually pay. Now, they don't pay everything that the hospital thinks it wants, but it's standardized. So we got the payment information from Blue Cross Blue Shield and it's done through something called the Michigan Value Collaborative, which is another group Don Berkmeyer and Justin Dimmick started at our place a while ago, and that is the repository of all this payment information. So what we decided is here's what's going to be in the 90-day payment data. The DRG, the surgeon's fees, anesthesia consults, readmits to the hospital, return to the ED, and admit to a skilled nursing facility. And then what we did was, in order to standardize this, when payers pay something, they don't pay every hospital the same. It should come as no surprise, but there's different contractual relationships that they have, and so that if that's in the data, you're not going to be able to compare apples to apples very much. So we have to get rid of those contractual adjustments. And the same thing, DISH payments, which are disproportionate shared payments, for hospitals that are in disadvantaged areas, that you're going to get that out of there. We also took GME costs out of there. So it's hopefully all these payment figures are standardized in that way in Michigan. That's kind of unique. I don't think many other places have something like that. So now what you're seeing here is the total hospital episode payment for colectomy in Michigan, and that's the 90-day thing, I think, yeah. And so there's some hospitals are getting paid significantly more than other hospitals that are getting paid significantly less. And typically what happens is these hospitals get a little defensive and they say, oh, well, yeah, but we have an outstanding hospital. These patients are getting excellent care, and you have to pay us because you want your patients to get good care too. And that's, that may be the case, but that's the whole idea of value, trying to understand that a little bit more clearly. So we can parse this data out any way you want to. I just show you here in this particular kind of high cost case, I can look at the total episode payment, total facility payment, the readmits, outliers, home health, rehab, all these things. Interestingly, the surgical payment was $2,100 for the colectomy. Anesthesia was more than half of that. And then the E&Ms and so forth and so on. But I've got this data, and computers can do anything. So you can just use it however you want to, whatever you want to analyze. So now we've got the quality, we decided was the composite, and then we've got the cost, which was really the payment information from Blue Cross Blue Shield, and now more recently we're doing it for Medicare also. But so now we want to link those together and get this value thing. And here's how you can kind of conceptualize it. All these dots are hospitals, and you have the payment on the y-axis here. And in this particular case, I wasn't using the colon composite. I think I was just using any morbidity on this, but it doesn't matter. The concept was that you want to be in the area where there's low cost and high quality. That's where you want to be. And the hospitals up here, as I said before, are going to say, well, it would cost us a lot of money, but we're better. But that shows that they aren't really, because they had a lot of complications also. So now we can take, I'm just reminding you about this composite score again. I just showed it to you. This is the quality composite. And here's the total episode payments on the basis of the different hospitals. And then if you divide those two, you get something that looks like this, what I call the hospital value index, where these hospitals all have good value because they have good quality in terms of the composite and lower cost, and these not so much. And that's where I think we're going, because this, we can now go into these hospitals, the green bar hospitals, and say, now, what exactly do you think accounts for having good quality but at a lower cost? Because if you can share that kind of information with us, I think that's going to be really, really important. And then we distribute that information to these hospitals, and in the end, we improve value across the state. Now, this is one slide that I really like, and Dr. Bohr, I was thinking about you, and you liked this slide when you saw this. But each one of these little dots is a colectomy operation in Michigan. And what you see here is the total episode payment for that colectomy. And here you see the composite score. So the slope of this thing is going this way, which is to say that higher quality actually costs less. And it gets back to this idea, when you have higher quality, you have fewer complications. And there's nobody that's eviscerating or, having a pulmonary embolus and all those kinds of things. And so it costs less. You don't get paid as much. And that, I think, I love to see that, because now I can show this to my Blue Cross Blue Shield friends and say, listen, we're doing something good here. We're improving quality within our collaborative, and it's costing you less money, so you need to keep supporting us, which, believe me, that's a yearly battle, but we've succeeded so far. So, okay, so the summary about this part is that when you have a hospital group like this, where there's a friendly collegial atmosphere and where the data is protected, I didn't have a chance to mention that, but we are a patient safety organization, so we have a double firewall around all this data. No malpractice lawyer or newspaper can get at this stuff. But we developed this high positive culture. We focus on high need, high cost areas. We define quality and cost. We look into the high value providers. We give data back all the time, distribute the information, integrate as much as we can, establish appropriateness criteria, and then we keep doing that. So that's how our system works, and it's working pretty well. But the last, I'm just going to end up on this note, that you also, it not only is it important to talk about money and quality, but you also have to have some kind of a platform for innovation. And I heard a lot of nice presentations this morning in the ways that you in the military are trying to innovate, which I think is great. But I'll show you, in this area, with this platform of hospitals working together, we had three sort of interesting innovations. And one of them, this is video coaching. Now this, I'm not taking credit for this, came from my partner, John Berkmeyer and Justin Dimmick. But the idea, if you remember that New England Journal paper a while ago, they looked at bariatric surgery, and they looked at 29 bariatric surgeons in Michigan. They were each asked to send in their best ever tape of obesity surgery. And then they were anonymized, and then those were graded by experts, and from the scale of the best to the worst, and then that was juxtaposed to results. And what they found, and it's kind of hard to see from this darn thing, this was the paper in the New England Journal, but what they found was the surgeons that were ranked best in terms of their operative technique had the fewest complications, and conversely. So that opens up an opportunity for coaching, because now we're not into this to be judgmental about any surgeon. We're interested in trying to improve all surgeons in their technique. So we now started in our MSQC group a colectomy coaching initiative, whereby surgeons are starting to send just a little jump drive of their best ever colectomy. And then we can use, the American Society of Colorectal Surgeons has a standardized template for, how long it should take you to get from point A to point B, and how you, dealt with the tissue and various other kinds of things. But we can do that, and then each surgeon gets to evaluate other surgeons, so they can see how other surgeons do the same thing. And you end up learning a lot from that. That's a very hands-on way to improve. So this thing is touchy. So the second thing is better pre-op risk assessment. And this came out of the MSQC data, mostly my partner, Mike Anglesby. But we have better pre-op risk assessment. Well, you know, you're used to looking at albumin and whatever that we used to do to look at this. But here's a completely different way of assessing risk. And that is using CT scans. And it came out of really the trauma experience. We got, you know, thousands of trauma cases in Michigan. And we started looking at CT scans to judge the nutritional status of the patient prior to surgery. And these are two cases that are almost identical, 58-year-old male with diabetes and previous MI and COPD, et cetera, et cetera. They looked a lot like the same patient, but if you look at the psoas here on this particular guy, kind of a wimpy, asthenic psoas as opposed to this big, robust psoas on this side. And if you just standardize it and do it at C4, C5 every single time, the computers can, you know, give you a very, very detailed number about the area, cross-sectional area of the psoas muscle. And then when we looked at all our patients with regard to that particular metric, this was the adjusted complication rate here, and this is the tertiles of core muscle size. So this is the group that had the smallest, wimpiest little psoas muscles, and these were the largest muscles. So it's sort of a nutritional state. You can do that for a number of different areas, not just psoas muscle, but you can look at intercostal muscle thickness at a certain area, or the number of you know, centimeters of fat, or there's all sorts of things that you can do. But this worked very well for us, and we're using it more and more as a risk. In fact, we sent in and got a grant from the CMS Innovation Center that was based partly on that. So, but the third innovation was that we wanted to get patients in better shape prior to surgery. And this is, you know, it's not necessarily a new concept, but we wanted to do it in a good way. So we put it into 40 different MSQC hospitals, this whole idea of, I call it a boot camp, surgical boot camp, where we do progressive ambulation. Many of our patients, you know, are kind of slovenly, and you give them a pedometer and ask them to get up to 8,000, 10,000 steps a day rather than 2,000 steps a day. Smoking cessation, glycemic control, improved nutrition, cardiac optimization, and patient empowerment. So this is done in the 30 days prior to elective surgery, if it's possible. You know, somebody got cancer or something, you might not be able to do it. But in this particular, a lot of cases, we can do that, and we get them in better shape. And the hypothesis is that if you're in better shape prior to your big operation, then you're going to do better. And remains to be seen whether that's going to happen. But it makes a lot of sense because, you know, if you're going to run a 5K or something, but you weren't a runner, you probably wouldn't just start off running the 5K. You'd try to work up to it. And it's amazing, if you look at this literature, it's really amazing how fast the human body responds to this kind of challenge. It can happen in a matter of days and weeks, and I think to the benefit of the surgeons. And how many times have you know, the anesthesiologist glares daggers at you because the patient is coming into the operating room. You're going to operate on this guy? And hopefully we can get away from that kind of thing. So that's the end of my story. I'd be happy to answer any questions later. I think there are some parallels that could be in the military group, although I'm not, you know, entirely familiar with that. But let's think about that. Thank you.